Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget that you can download the PDF of this document down for the description below. And feel free to like and subscribe to the channel if you enjoy the content. So let's jump into it. So the first thing we're going to do is we're going to look at the force to get an idea of what's going on with this rhythm. I look here, maybe a V5, and I notice I've got a narrow complex rhythm that seems to be pretty regular, and it seems to stay that way for the entirety of the strip. When I look in front of my QRSs, you can see there's a lot of artifact on this ECG, right? You can just glance through and see there's a ton of artifact. But if you look closely, you will see that there are some P waves that occur before the QRS complex, right? Here's one, right? Ton of artifact, but you gotta kind of see through it. And so our rate here, if we find a QRS on a solid line, is 300, 150, 175, 60, just under 60, so maybe 58 beats per minute. So just a mild bradycardia. Okay. So let's evaluate what the atria is doing, right? We said that we had P waves, and what are they like? Well, those P waves seem to be upright in lead 1, and they seem to be upright in AVF, so I would say that these are sinus P waves. So we've got sinus bradycardia. I think about what is my AV node doing, what is that PR interval doing, and so I look here and I see that from the beginning of my P wave to the beginning of my QRS, my PR interval is a little bit long. My PR interval is like 7 small boxes, which is 280 milliseconds, right? We know that that is too long. Normal needs to be 120 to 200. And so we need to make sure now that every P wave has a QRS, and so you scan through and you see that does seem to be the case. And I look for any extra P waves. I don't see any. Okay, so we get normal AV node function other than it just takes too long. So what does that mean? We have a first degree AV block, right, where every P wave makes it down to the ventricles, right? Every P wave coming from my sinus node gets captured by that AV node, and when it gets delayed, it just gets delayed for a little bit long, and then it passes it through, right? So now we get our QRS complex. We said it was narrow, and if we measure it, the QRS complex is less than 120 milliseconds, which is fast. It makes me think I'm taking my His-Purkinje system. My QRS axis is upright in lead 1. It's upright here in AVF, so it tells me that it's going down and to the left, which is normal. I've got good R wave progression, maybe a little bit late. You can see little itty bitty septal R waves that are progressing. They don't progress until V5. They get almost isoelectric, and then V6. So maybe a little bit of late R wave progression. That's okay. And so now we need to have it for our QT interval, right? And so our QT interval will find a QRS that's maybe this one here and this one here, and you can see my T wave ends well before that midpoint. So it's normal QT. Now I'm going to look for ST changes and pathological Q waves for my ischemic changes, and I think you all pretty much are going to hit this one on the head. We're doing a lot of inferior STEMI work this month, and that's not by coincidence. It's because they come in all different flavors, right? And you need to just have your eye ready for it. And so if you look at the inferior leads, you can see all this ST elevation in the inferior leads with these hyperacute T waves, So we've got ST elevation and hyperacute T waves in my inferior leads. I've got reciprocal depression in my lateral leads, right? Look at AVL, reciprocal depression, and lead 1. So we've got reciprocal ST depression in the lateral leads. And then you also notice that V2 has ST depression. And so that tells me that we might have some posterior involvement with this infarct, right? Some posterior involvement with this myocardial infarction. Remember that 80% of the time, the right coronary artery, which supplies the inferior myocardium, also supplies the posterior descending artery, which is why we get posterior extension of right coronary artery infarcts. And so that's what we get here, is we're having a right coronary artery infarct. And so we put this all together. What do we have? We've got a sinus rhythm, sinus bradycardia at 58 beats per minute. We have a first degree AV block, and we have an infero posterior ST segment elevation myocardial infarction. So hope this helps. This person was taken to the cath lab and received a stent in the right coronary. And if you think about what does the right coronary do, it supplies the inferior and sometimes the posterior portion of the myocardium, but it also supplies the SA and the AV node, right? And so that might explain why maybe this person's sinus bradycardia is because that SA node is kind of taking a little bit of a hit from this myocardial infarction. And maybe that first degree AV block is also some evidence that it's also taken a hit. So think about the anatomy, it's pretty neat. I hope you enjoyed this video. If you have any questions about right coronary artery infarcts, please feel free to ask. And if not, thank you so much for watching. Have a great rest of your day. We'll see you on the next ECG video. Take care.